morning. I'm MMAC President Tim Sheehy, and I want to thank you for joining this weekly webcast on business strategies during the pandemic, Tuesdays from 11 to 12. MMAC's mission is to develop Metro Milwaukee as a globally competitive location for businesses that deliver high-value jobs to foster a vibrant quality of life for all. This program is designed to provide actionable insights into the challenges and opportunities we all face in bettering this region as a place to live, work, play, and learn. We're going to start with a COVID-19 update from Dr. John Raymond, President of the Medical College of Wisconsin. He's also going to be joined by Dr. Hari, Chief and Professor of Hematology and Oncology at the Medical College of Wisconsin, and Dr. Price, who's an enterprise epidemiologist and professor of medicine in the Division of Infectious Diseases at Frederick and the Medical College of Wisconsin. And of course, if you want to catch an update this afternoon on 6:20, instead of being on at 4:20 today, Dr. Raymond and I are on at 3:20, and you're welcome to join us then. And again, as you have questions, we will engage to answer those questions following our presentations. So with that, Dr. Raymond, I'll turn it over to you.
Yeah, thanks, Tim, and good morning, everybody, and thank you for joining us here and also for being able to switch platforms. We're really grateful for your presence. Before we get started, I'd actually like to introduce Chris Jenkins, if he can come on screen. Chris is the man behind the slides, and he's our moderator. Chris, can you just give a wave to everybody?
Hi, everybody. Thank you.
Yeah, thanks, Chris. Really appreciate everything that Chris does to make these webinars so impactful and professionally run. Thank you, Chris. So I'll get on to the first slide. We typically start with testing, and we've administered over 1 million tests in Wisconsin, 1,062,000. And in Milwaukee, we've had over 200,000 tests at 208,000 tests. Now, we've had 61,000 positive tests in Wisconsin for a 5.7% positivity rate. We've had 21,000 positive tests in Milwaukee for a 10.2% rate. Yeah, thank you, Chris. Now, ideally, the positivity rate should be consistently under 5%. I do want to note that the positivity rates that I showed you, 5.7 and 10.2%, are averages since the beginning of the pandemic. And we've actually been doing better, tracking at about 6% in Wisconsin and 6% in Milwaukee over the last few weeks. And the reasons that that's important is that you want to be under 5%, because that's a good indicator that you're testing adequately in your community. And under the ideal circumstances, you'd want that rate to be down to maybe 1%. I do want to point out that early in the pandemic, about half of the cases were in Milwaukee. And as the pandemic has matured and spread throughout Wisconsin, you're seeing now that we've had about 1/3 of the cases since the beginning of the pandemic. Now, yesterday was a relatively light day for reporting, with 8,167 tests reported. And that's pretty typical. Monday and Tuesday tend to be our lowest reported days. Now, the testing capacity in Wisconsin is stable at a little over 24,000. And one thing I want to point out to everybody is, even though we have pretty good capacity in Wisconsin, there are new concerns about the supply chain. And this was reported yesterday in the Wisconsin Health News and discussed by us last week. And in fact, one southeastern Wisconsin health system had to pull back from community testing sites due to shortages of testing reagents. So this is something that we're going to need to monitor over the next few weeks. Now, there are 83 laboratories currently testing, with 24 planning to test, and that's been stable over the last few weeks. Now, the daily positive tests have really increased over the last month, and we've had many days over 1,000 recently. Now, Saturday was our highest single total day of reported positive tests in the pandemic in Wisconsin since it started at 1,165 positive tests. Now, yesterday there were 507 reported for a 6.2% positivity rate, and 142 of those in Milwaukee for a 6.4% 7-day average. Now, a couple of things to observe here. The daily positives are trending slowly downward. So we did reach a peak of new positive tests a few weeks ago, and that's trending downward, but very, very slowly, but that is favorable. The positivity rate also is trending very slowly downward, and again, that's favorable. I want to remind everybody that the number of positive tests and the positivity rate are early indicators. I did want to mention something that's reported every Wednesday, so these data are a little bit old, but it does bear some discussion about the trajectory of the pandemic. And you can actually look at that on the Department of Health Services website. So last Wednesday, 66 of our 72 counties reported high COVID-19 activity, and the other 6 had medium activity. Those were Bayfield, Florence, Green Lake, Rock, Rusk, and Vernon. So it's important to note that there's not a single county in the state, at least as of last Wednesday, that had low activity. There also were 9 counties that had high activity that were trending favorably, and those included both Milwaukee and Waukesha. However, there were 14 counties with high activity that were trending unfavorably, and those included Racine, Ozaukee, Washington, and Walworth in our area. Next slide, please. I want to talk about cumulative hospitalizations. You know, we've done pretty well in Wisconsin since the beginning of the pandemic, but we still have over 5,000 hospitalizations. Now, if you have a positive test in Wisconsin, your likelihood of being hospitalized is 8.3%. And recall that early in the pandemic, we were hospitalizing just about 30% of the patients that had a positive test. Now, there are a couple of reasons why this is trending favorably now, down to 8.3%. I think the most important of which is that we have a significant increase in our testing capacity, so we're able to test people earlier. That allows us to provide treatments earlier and supportive care earlier. Secondly, we've learned an awful lot about COVID-19 and how to provide supportive care to patients with COVID-19. You're going to hear a little bit more about that from Drs. Hari and Munoz-Price later on. Now, we had 414 inpatients in Wisconsin hospitals yesterday with COVID-19, and that is rising very significantly, up about 50%, or actually almost 90% from the low on July the 4th. We're not near our highs that we experienced back in March and April, but this does bear watching. We had 119 patients in ICUs, and that also was rising compared to a low of 65 on July the 5th. So again, when we've seen an increase in the number of positive cases, that started about a month ago. There's a lag between the time period when we see an increase in number of new cases and we see hospitalizations. So the hospitalizations and ICU use are lagging indicators. Now, in terms of our ICU capacity, we have plenty of beds available, with 312 available yesterday, but that bed count seems to be declining just a little bit. We also have very adequate ventilator capacity with 1,641 ventilators available. I do need to mention that we were tracking at about 900 to 1,000 available ventilators, but when the reporting requirement was changed from the CDC to HHS, they also requested that hospitals include easy surge capacity ventilators. So these would be ventilators that you could repurpose from procedure rooms and recovery rooms. So that also includes some surge capacity, and I wanted to make sure people understood that. Just in terms of personal protective equipment, our trends are stable with most critical needs of goggles, gowns, and paper masks. But I do want to mention that our health systems have expressed some new concerns about the fragility and the vulnerability of the PPE supply chains. So again, that may be a limiting factor for us in the future. Next slide, please. This next slide shows that we're approaching 1,000 deaths in Wisconsin at 998 since the beginning of the pandemic, with 389 of those thus far in Milwaukee. And I need to point out that death is a highly lagging indicator. Typically, early in the pandemic, when you saw a spike in the number of cases, the deaths lagged about 4 weeks after the number of cases went up. And there are a lot of reasons for that, including the lag time between symptoms and diagnosis, the period of time it takes to put someone in the hospital, for them to progress to the ICU and then to die. There are weeks involved in those lags. I think the lag has extended even more recently as we've gone to a younger demographic of patients testing positive for COVID-19. So they're less likely to require hospitalization, although many of them still require hospitalization. But more importantly, they can pass that infection along to susceptible older individuals, and that lag may be another week or two. So we would expect that after increase in cases, the deaths might not really occur until 4 to 6 weeks later. Now, the deaths as a percentage of COVID-19 cases, what would be called the case fatality rate, is tracking now at 1.6%. And that also has improved significantly since the beginning of the pandemic, when we were seeing here in Wisconsin rates that started out at about 10%, and then we were tracking at 5, 4, and 3. I think this reflects the better care that we're able to give to patients with COVID-19 and early detection that's been enhanced by the availability of testing. I also think that because of aggressive moves that the states made to intervene in congregate living situations and in employment situations in which people work closely together, such as food processing plants, we've also been able to lower that case fatality rate. Now, the death rate in Wisconsin and Milwaukee appear to be flat right now, but it's noteworthy that we had a clear uptick in deaths toward the end of July. And that, again, would be expected because of the lag phase that we have from the increasing number of cases that we've experienced since late June. Now, deaths, like the number of newly diagnosed cases and positivity rates, do disproportionately affect people and communities of color, as shown in the table on this slide. Now, I'm not going to go through all the data on the table, but I do want to mention some trends that we've been tracking over the last few weeks. When examining total deaths, there have been increasing percentages of deaths in whites and Hispanic individuals and decreasing percentage of deaths in Black and African American individuals. Now, this really isn't surprising because the new cases have been trending toward white and especially Hispanic populations for the last 2 months. Now, in terms of other indicators, the doubling time continues to extend out to 36.4 days in Wisconsin and 45.3 days in Milwaukee, and we want to see that doubling time continue to extend out. Now, this does seem promising, but what it actually means is that without a change in the rate of growth of our pandemic, we're going to have 60,000 more cases of COVID-19 in Wisconsin by mid-September and 20,000 more in Milwaukee by late September. So we do need to stay on top of all of the interventions that we know work. The 7-day mean growth rate continues to go down, which is favorable, 1.4% in Wisconsin and 0.9% in Milwaukee, but the same caveats apply to the doubling time. Now, the reproductive number is under 1. It's 0.96 in Wisconsin and 0.95 in Milwaukee as of yesterday. And as you know from previous webinars, ideally we want that to be substantially below 1.0 in order to decelerate the pandemic. Now, the good news is that for the last 2.5 weeks, we've been at or under 1, with that favorable trend particularly clear in Milwaukee. On the other hand, we have a high burden of disease, so continued vigilance will be essential. Now, this slide compares the 7-day mean reproductive numbers since early March for Milwaukee, shown in gold, and Wisconsin in blue. And starting at the left, you can see that we took a troubling turn in mid-June with reproductive numbers climbing over 1.0 for 40 consecutive days. Now, the Milwaukee mask ordinance went into effect on July 17th, and a few days later, the 7-day average reproductive number dipped below 1, and it stayed there for the last 2.5 weeks. Now, Wisconsin also dipped under 1 and has remained at or slightly less than 1 for the last 2.5 weeks. And for your information, the Dane County mask ordinance went into effect on July 13th, and the Wisconsin mask order went into effect on July 30th. Next slide, please. Now, my final slide shows the lag between new cases, shown in gold, and the deaths, shown in blue, that I've been talking about on previous slides and in previous webinars. Now, although the trends might not be easy to track due to relatively low numbers compared to other states, I'd like to draw your attention to the middle of the graph. The left-hand red dot shows the inflection point of clearly increased daily case counts in mid-June. The right-hand dot shows the inflection point of increased daily deaths, which occurred about 5 weeks later in mid to late July. Now, the reasons for the lag include, for the primary cases, the time to hospitalization, ICU use, and death, and for secondary cases, from exposure to symptom development, hospitalization, and death. And because the demographic has shifted recently to younger individuals who are less likely to require hospitalization, that lag may be further prolonged until the infection's been passed along to older family members, customers, coworkers, and friends. So to summarize, we do continue to struggle with COVID-19 in Wisconsin, perhaps doing better in Milwaukee than in other parts of the state. Now, the early indicators seem to be stable or slightly improved over the last few weeks, but deaths have increased from the lows that we saw in early July. So we strongly advise continuing vigilance. And with that, I thank you for your attention, and I'll turn it back over to Tim.
Thanks very much, Dr. Raymond. Maybe a couple of quick follow-up questions for you before we go to a short presentation by Dr. Hari and then Dr. Price, and then we'll open it up again to questions, and I've got some of my own. But one of the questions from one of the viewers is, it seems that the virus is mutating, and as it mutates, is it weakening?
Really good question. The virus is mutating, but at a slower rate than many other respiratory viruses like influenza. And there is one mutation that has been proposed to make infection or contagiousness more effective, but it doesn't make the virus stronger or weaker. And so to answer the second part of the question, the virus clearly is not weakening. I think that we're just getting better at providing supportive care. You're going to hear more about that later in the presentation.
Thanks, Dr. Raymond. The other question goes to what's being done about false positive test results. And the questioner would like to know if any of the panelists have insights into rumors that in several states, there have been people that have been waiting in testing lines, provided contact information, left the testing site because the wait is too long, and then subsequently receive a letter in the mail stating they've tested positive when in fact no testing has been done. As a community trying to abide by the guidelines, the statistics are obviously extremely impactful and have altered the course of everything from hospitality to education industries. So the real question is, can we trust the numbers that we're seeing in the state of Wisconsin? Are they an accurate picture at this point? And what checks and balances are in place in the state of Wisconsin currently to ensure ethical reporting and testing of hospitalizations and deaths?
Yeah, that's a lot. Those are a lot of questions, actually,
yes.
But it's an important topic. Let me just say that in general, I believe that you can test the aggregate numbers that we have in the United States. Probably we have better reporting here than many other countries in the world. And I'm sure that there are mistakes in reporting, there are lags, there are reclassifications that happen from time to time based on evolving knowledge. So I think that starts some of the confusion. I personally do not believe that there are large numbers of people who don't get tested and leave testing lines that end up testing positive. In fact, I've seen lots of that on social media posts. And when people are challenged to provide names and locations, they generally aren't able to do that. So I would say I'm very skeptical that there's any systematic attempts to either increase or decrease the number of COVID-19 reports. In terms of false positives, the PCR test, that is the standard test where you do the deep nasopharyngeal swab, has very low false positive rate. It's very, very reliable test. When you start with the newer tests, like some of the antibody tests or the antigen tests that are being rolled out right now, they may have false positive rates, but in general, false negatives tend to be the real problematical issue with testing.
So let me, as a closing question here, at least for this first part, and then we'll move on to Dr. Hari and Dr. Price. So given what we've learned from the COVID pandemic and in treating its spread to date, what, Dr. Raymond, are the best indicators we have of its current status, and what do they tell us? And let me just have you answer that question in three buckets. One is kind of the metro area, the state of Wisconsin, and then the US.
Well, I think for the entire country and each state and for our state, the metrics that are important are all the same.
Okay.
And let me just start by saying there's no one metric that tells you the full story. You need a panel, and that's why we've tried to talk about early indicators, lagging indicators, and then death, which is the ultimately lagging indicator. And it's like looking at a movie, and you're trying to project what's going to happen later on in the movie. So one thing we know for sure, irrespective of whether people that are testing positive are younger than they were earlier in the pandemic, if you triple or quadruple the number of people that are testing positive for COVID-19, you're going to have more people in the hospital 2 to 4 weeks later, and you're going to have more deaths that happen, as we showed here, 5 weeks later. So from my perspective, I like to look at the reproductive number. I like to look at the number of new tests, and I like to look at the positivity rate as the early indicators that tell you what things are going to look like a month down the road. For all of us early in the pandemic that worked really hard to slow the pandemic down because we didn't want to overwhelm hospitals, those intermediate indicators of hospitalizations and ICU use are important, but they're going to come a month later.
Good. Thank you very much. So I know you're going to stick with us. Dr. Hari, I'm going to turn it over to you.
Thanks very much, Mr. Sheehy, and thanks, Dr. Raymond. So I will talk about one particular way of treating this disease. My background is in cancer care and immunology, so we'll just talk about convalescent plasma. Can I have the next slide, please? So this is important because, as Dr. Munoz-Price will tell you a little bit later, this is one of the technologies by which we can actually provide some proven relief to patients with COVID-19. So the convalescent plasma has been in existence for viral illnesses for more than 100 years. It was, in fact, used in the big flu pandemic of 1917-18. So the principle is this: if a person recovers fully from COVID-19 infection, we would expect their blood to contain antibodies, which are proteins or chemicals made by our own immune system that can neutralize the virus. In fact, that would be an important thing that would help that particular person recover from the infection. And we make a lot of antibodies against the virus, but there is at least one which we now know, which is effective in preventing virus replication and takeover of the person's body, and that's the SARS-CoV neutralizing antibody. It is specifically attacks the outer coat called the spike of the virus, and that's what we look for. So when we first started doing this, we didn't know what we were looking for. Now we have a lot more information. So here is how it works. Patients who have recovered from COVID-19, so we need somebody to have had a definitive positive test on PCR, and then to have recovered from that infection by day 28. So that's the vast majority of people, as you all know. That person is then eligible to donate their plasma. So they go to a center where their blood plasma is collected on a machine. And if many of you, I'm sure, have donated blood and plasma, so this is an easy procedure. It really does not cause any harm to the donor, except for the nuisance of a vein stick in vein. This plasma then gets separated and processed into bags. We test it for other viruses and other blood transmissible infections, so it's perfectly safe to the recipient. For patients who are critically ill with COVID in the hospital, we can give this plasma as a means of transferring passively the antibodies that this donor actually produced, and the donor immune system's antibodies are transferred to the patient. So we have a national FDA-sponsored program that was run by the Mayo Clinic and the FDA together that has treated almost 60,000 patients. And as Dr. Munoz-Price will tell you in a bit later, there is sufficient proof that that has caused mortality to decrease in the patients who got treated. It's still a small number, and we definitely need more donors to come forward and donate plasma. So that's also takes us to the point that if you're tested positive and you get better, you have an opportunity to help the people who get seriously sick. And it's favorable in this disease that the majority of patients do get better quickly. Their immune systems do work as designed, and that will help us have this drug available for patients who are critically ill. Turns out that plasma is best used early in the infection, not in the later stages of infection. So we are still a little hampered that we are treating patients in the hospital. Ideally, we would like to treat them even when they are coming to the ER. And at that point, giving them plasma would be actually more beneficial. So there are clinical trials that are looking at that too now. Within MCW and Frederick Hospital and this campus, in the Frederick and MCW system, we are blessed in Wisconsin to have Versity, which is otherwise known as the Blood Center of Wisconsin. So Versity and us, we actually started a clinical trial. And as I'll show you in the next slide, the aim is not just to give plasma as is in the FDA program. That is actually an access issue that is solved with the FDA and the Mayo program, that everybody gets it. We are actually trying to find out which component in the plasma helps the patient. So we are actually collecting blood from the patient who is receiving it. We are analyzing the plasma to identify which particular component of that antibody works against the virus and helps the patient. So this is the crudest form that we do. We collect the plasma, give it to the patient. So the next step is to actually identify which component in the plasma works and find that out. And so that can be used by pooling multiple donors' plasma and just concentrating the part of the product that actually helps the patient. So if we concentrate the immune part of that plasma, we call that a hyperimmune globulin. This is also in use in many viral infections. So this pooled plasma derivative called hyperimmune globulin is our next step, so that we can take it off the shelf. We can collect it from multiple individuals who have recovered from COVID-19, and we can pool the plasma and take the essential element and make it into a drug, and that can be used. So this is again going to help people. And finally, we have a grant which Versity and investigators from MCW, including myself, have actually put in to try to actually make it commercially without actually having to rely on donors who have recovered. So you don't need people to go in and give it. We can actually we have technology called recombinant technology. We can actually make this protein and manufacture it commercially. And so there's companies that are in clinical trials. The FDA actually just last week asked 2 companies to go ahead and start doing these clinical trials. So plasma is actually a gateway to many other ways in which. So we're all worried about the vaccine. The vaccine actually gives you active immunity, which means your immune system learns how to fight the virus, whereas plasma gives you passive immunity. And plasma-based approaches like hyperimmune globulin and a monoclonal antibody that we talk about here would give you immediate protection, even without the active immunity kicking in. In an ideal scenario, we would have both. This would help people who are already infected, and the vaccine would help people who are susceptible but not yet infected. So that's, and then I think we go to Dr. Munoz-Price.
So, Dr. Hari, a couple of follow-up questions before we get to Dr. Munoz-Price. Can you donate plasma if you've had a positive COVID test? If somebody thinks they had COVID-19, they can't be tested for the antibodies?
So the current rule, as it stands today, is that you have to have had a known PCR test that was positive. But we will soon be changing that rule, where if we have a reliable antibody test and we can show a specific titer of antibody, so you have to have enough antibodies in the system, and then we can take those patients. So that's going to happen very soon. So even if you didn't have a positive PCR, you think you have recovered, you can go and get tested for the antibody. And if we find the right antibody, you could test.
Okay. And then if someone has not been able to donate blood previously due to history of infectious hepatitis, are they able to donate blood now if they have had a definitive positive COVID-19 test and recovered?
Unfortunately, patients who are permanently debarred from donating blood for various reasons, including hepatitis, they will not be able to donate because you have to be eligible to donate blood. That's a standard requirement across the country. So they wouldn't be able to donate if they've been permanently debarred. If you had a transient hepatitis that recovered and you were told, no, don't donate right now, then you could potentially come back and get tested again and donate.
Okay, and this may be a variation on the first one. What if you were not tested for COVID but had antibody test that shows you had the virus? Can you still donate?
So as of today, I don't think we can donate, but the FDA is loosening the rules. Actually, this is governed by law by FDA and AABB, American Association of Blood Banks, and the FDA. And they are actually seriously considering people who did not have a PCR, but do have antibodies to be able to donate, because we now know which antibody helps you, and we can actually test for those. So if we show that, then that person is going to be useful. Their plasma is going to be useful.
Are all of the antibodies collected from the donor, or just a portion, leaving some of the antibodies in the donor?
So our bodies have a lot of antibody when we are recovering from this infection or when we are immediately recovered. So what we collect is only about 300 ml of plasma. So there's the rest of the plasma, which is several liters, are in the person. So it's actually evenly distributed in the plasma, and we take a tiny amount of plasma. That's it.
Okay, and then last question. It seems that donated convalescent plasma would be relatively plentiful, while manufactured antibody would be too expensive.
Yes, but manufactured antibody, the cost of manufacturing, if we scale it up, would be actually cheaper than plasma, because there's always the economic impact of somebody taking time off of their day, donating time, sitting in the machine, collecting all that. But again, it's a commercial enterprise versus this is right now a clinical trial. So there's a little bit of that too. But again, that's economics, which is kind of beyond me right now.
Okay, thank you, Dr. Hari. Dr. Munoz-Price, thank you for joining us. And I'll turn it over to you.
Thank you. Good morning, everybody. It is my pleasure to be here with you this morning to talk about these issues regarding COVID-19. So next slide. I was actually asked to talk about the treatment options that actually have data to back them up. But before I mention this, just by listening to the questions, I'm going to just mention briefly about interventions that we can do in order to prevent exposure, to prevent prevention to transition to actually needing treatment. So prevention interventions can be divided into two: prevention of being exposed to the virus, and what you do from being exposed to the virus to actually developing disease. So let's talk about primary prevention interventions, which is how do I protect myself from getting exposed to the virus. And that is actually fairly basic. There is no magic behind it. Masks and social distancing. That's what's going to keep you away from getting exposed to the virus to begin with. So that's primary prevention. Secondary prevention, which is I know that I've been exposed to a person with COVID. So let's say my coworker who happened to be having lunch with me, and we were sitting right next to each other, and we weren't wearing masks, and now she has COVID, and how do I prevent from going to being exposed to actually having COVID? There's nothing at this point that you can do for secondary prevention, unfortunately. I know that online you might find different things like ivermectin. That's not proven. And I'm going to stop there regarding prevention. All right, treatment options. Just like secondary prevention, you can find many different things online of what you can do to treat this, but the only ones that have been proven are three and are here: Remdesivir, dexamethasone, convalescent plasma. So let's go one by one. Next slide. So dexamethasone, very cheap, very, very cheap. And it is a tablet, or it can be intravenous as well, that is given daily for 10 days. Now, unfortunately, this treatment works only in patients that are on a breathing machine or are sick enough that require oxygen. Patients who have COVID but are not sick enough that require oxygen do not benefit from this intervention, from this treatment. Next slide. Remdesivir. So Remdesivir is an antiviral. So it is an antiviral that is given intravenously. So the indication for this virus, this antiviral medication, is for patients that have low oxygen in their blood. So it is not for a lot of COVID patients have very mild symptoms. So this drug is not indicated for those patients. This drug is indicated for patients that are in the hospital that have low concentrations of oxygen, and this medication has not shown to improve mortality. What has shown to improve is time to recovery. So instead of taking 5 days to feel better, it takes 3 days, as an example. Next slide. And then, as Dr. Harry mentioned, convalescent plasma, there is a very large study being performed by the Mayo Clinic, MCW, Frederick MCW is part of it. They have infused 60,000 patients with convalescent, actually 90,000 patients with convalescent plasma across 2,757 sites. And what they have found is that mortality goes down with convalescent plasma. Now, it goes down especially if you give it early in the disease. And at this point, at least, it's indicated primarily for patients who are in the hospital. So if you have COVID and you're home, there's really no treatment that has proven to be effective to change your outcomes with COVID. And I'm going to stop there. Tim?
Thank you very much, Doctor. I'm going to bring Dr. Hari and Dr. Raymond back and then ask all three of you kind of to join us in answering the questions that we have. And I've got a couple more here I want to go to. One is, has anyone compared the number of deaths due to complications of COVID-19 to the overall deaths, including influenza, heart disease, diabetes, and chronic lower respiratory disease from prior years?
I'll start. The answer is yes. So far, we're tracking at about 200,000 excess deaths compared to previous years that have not been categorized as COVID-19 or other similar illnesses. And just to put things in perspective, we have about 600,000 deaths per year from heart disease and cancer, and we're tracking at 150,000, 160,000 plus now of COVID-19 this year.
Good. Another question here. I guess it's a question or a statement, and I guess it is, realistically, should we stop talking about a time when the virus is, quote, gone completely and just accept that this virus or some form of it will be with us for the foreseeable future, like AIDS, the common cold, flu, or et cetera, or others?
Yeah, that would make sense. This virus is going to be with us for the next years. And just like the person who is asking this question said, it might just stay with us, just like all the other coronaviruses. We have several coronaviruses and strains of influenza that circulate in the community. However, hopefully, the hope is that once we have a vaccine, we will be able to accomplish herd immunity so that the impact to our society is not as great as it is currently.
Thank you. Why is Wisconsin seemingly doing so much better than several other states, particularly our neighboring states?
So I can take that. I think culturally, we are probably a little bit more health conscious, and we may be a little bit lucky in that geographically, outside of the big metro centers, we are essentially socially distanced anyway. So those two things could have helped. The states that didn't really do well, they had much more closer, people living much more closer, big metro centers, and it spread rapidly among the older populations, which led to much higher mortality. We were lucky in avoiding those things, and just judging by the volume of my own patients with cancer, we've had a steady trickle of patients who got infected. but people are very law abiding in terms of when you tell them that this is a real issue that they need to be careful about. I'm just surprised at how responsive patients have been. So it's I think culture, geographic distance, and the populations being much more responsive to suggestion could have helped.
Thank you.
Hey,
Dr.
Tim,
Raymond, go ahead.
Tim, can I just say something?
Sure.
I want to give you and the MMAC some credit for very early recognizing the importance of providing well-curated scientific data to the general population and to employers. And I really think that has made a significant difference just in terms of why we're doing better than some of the states around us.
Thank you. So I've got a general question, Dr. Raymond, on masks. And as long as we've been doing this program together, I violated one of your tenets and jumped on an airplane because I had to get somewhere. And I wore a neck gaiter, and I saw lots of other people wearing neck gaiters on the plane. I understand there's new information related to neck gaiters as masks.
Yeah, really great question. And I actually bought 3 neck gaiters, haven't used them yet. So there was a study out of Duke University that was published this last weekend where they compared 14 different types of masks for the burden of droplets that people produce when they talked. And pretty much every mask did a really good job of reducing those large respiratory droplets, except for a bandana, which was a single layer cloth face covering, and for a neck gaiter. And one of the things I've been thinking about, and I read the study very carefully, is the neck gaiter was the only face covering that was made out of a synthetic fabric. So it was made out of polyester or fleece, which is a single layer with a lot of fluffy fingers sticking out on each side. And I believe that it's really important that we have multiple layers of either cotton or a blended fabric if we're going to get that protection. So one of the modifications, I don't think it's fair to say neck gaiters don't work. We really don't know that. My guess is that it really has more to do with the type of fabric used.
So another question here, which is very pertinent as we finish August and roll into September, and it has to do with schools. And we know lots of school districts around the metro area and the state are making different decisions. In the city of Milwaukee, where MPS educates about 66,000 students, they've chosen to open virtually. The other 46,000 students are waiting for the city, which is hopefully today going to produce the protocols for those schools that feel they can open safely in person. Could you speak to the data about the escalating rate of COVID-19 in children, and do you suggest that schools rethink the decision to meet in person?
Shall I go?
Yes, please.
Well, I've been doing infection control for over 10 years. One of the main challenges in infection control is to translate what you put in paper to what actually happens in real life. So I think it was a smart decision to keep the public schools online, even though it has its challenges. But unless you have a way to enforce and assure that what is in paper happens in a daily basis, then we're going to have a problem. So I think that the schools that have decided to go hybrid, I hope that they're prepared to translate what they have in paper to actual actions, because if not, we're quickly going to see an increase in the numbers of positive tests in our young population.
So this goes to a question, Dr. Raymond, you and I have talked about multiple times, and we'll use the education example and Dr. Price's answers as a sample of this, where one decision is to protect the health of the students, an important one. Another decision affects their ability to learn remotely. Students who don't have a stable home environment, and the impact on parents who need to go to work. So as doctors, you're juggling these multiple impacts. How do you all think about balancing out the impacts of these decisions?
Yeah, that's such a hard question, Tim, and there is no one right answer because we're all, including places in the world where they're starting to reopen schools, learning as we go. So a couple things to think about in terms of reopening schools. It isn't just the schools. It's how much of a burden of COVID-19 do you have in your community and what direction is it going? That's a really important consideration. So right now, some of our communities on the North Shore have lots of testing done and almost no cases. So there's not a high burden of community spread there. Other parts of the city like West Milwaukee and the near South Side have a lot of cases. And so you may need to think about going back to school differently there. It's also important the physical facility that you're going into and the ability to socially distance, to mask, to do bubbling or pods or cohorting and keep the kids apart in small groups is going to be constrained based on the physical plant that you have, the ability to change your air exchanges and filter the air through your HVAC matter. And then I think what you're getting to, Tim, has to do with, is the family really prepared to have kids at home or to send them to school safely? And all those factors really have to be put together into one picture. And there's no right answer. What I would say is the best we can do is try to keep the cohort of students small who interact with each other, keep them from interacting with each other, wear masks, wash hands, socially distance, sanitize, and do extra things to protect the safety and welfare of the teachers in particular. So I think universal masking and maybe even having plexiglass shields or face shields or goggles for teachers would be a good idea. And I know you've talked about the mental health aspects, particularly for children. It's important that they socialize with each other. You learn a whole lot more in school than what you learn from the book. It really is how to get along with each other in society. And it'd be a shame if we had students miss out on a year or two of that learning opportunity.
Yeah, thank you
both.
And
Tim, just to add to that, just to emphasize that for transmission to happen, you need to have a cluster of people that are at risk, and you have to have someone that has the virus that is carrying it. Mm-hmm. If you have either one separately, you're not going to have cases, right? So if you have a cluster of 50, 100 students, but that are not socially distancing, but nobody's positive, then you're not going to have transmission. Similarly, if you have a cluster of students that are socially distant, but somebody's positive, then you're not going to have transmission either. But if you have a community that has a lot of COVID in the community, and you have a school that is unable to keep kids socially distant, then that's when you have a problem. You have the combination of the two things that you need, which is a group of people at risk with people that are positive.
Mm-hmm. Question, linking the theory that our exposure to the common cold and our immune system response and the milder symptoms or asymptomatic response to COVID-19?
This is perfect for Dr. Hari.
Yes. It seems so. Just to get to a little bit of background on this, there was a ship that went to Antarctica from Argentina, and without much social distancing on the ship, about 200 odd people, and about 55% of them got COVID or were tested positive for antibodies, suggesting that they could have had asymptomatic infections. But at least another 50% did not have, did not catch it or develop antibodies despite frequent intermingling, etc. And the ship had a lot of difficulty when it came back. They wouldn't let it dock, so they had to be out at the sea, etc. So this led to a hypothesis that some people are probably baseline immune from getting COVID. And it's quite possible because there are 4 other coronaviruses, which are the classical common cold viruses, which we all get multiple times throughout our lifetime. And a couple of studies, especially from a group in Germany, have shown that you may have baseline antibodies that are present, which have what we call cross-reactivity with the COVID spike protein. In fact, a low level of baseline antibody could mean that you need a very high inoculum to get infected, meaning like you have to have really big exposure, or could be that you wouldn't get it anyway. And even if you don't have antibodies, this group in Germany also has shown that some people have T cells, which is a type of immune cells in your body that actually help make antibodies by the B cells. And also they are kind of immune memory for a long time. So we call them memory T cells. So when you take normal blood donors' T cells and expose them to COVID proteins, some people, as a percentage of people, about 25 to 35% of people from a normal population, blood collected many years before COVID actually hit the world, those people's T cells could respond to it as if they had memory about COVID. So it suggests that there could be some kind of baseline immunity, which actually bodes well for a vaccine, even if it's not super effective. If the vaccine just converts some percentage of people to this level, and plus the people who maybe who have some baseline protection, that might actually help us live in a better situation. So that this is one of the things that makes me very optimistic for the future.
Your thoughts on the effectiveness of a vaccine by year's end, or 6 months further? Where are we, and what thoughts do you have today on a vaccine?
So I can finish that thought. So the 3 major vaccines that are going ahead in the Western world, there's news reports about a vaccine in Russia about which we don't know much because it's not in the published literature. All of them seem to be relatively safe, given the small numbers that have been tested so far, seem to be able to produce some amount of immunity, both in terms of producing an antibody response and a T cell response. And in case of one of the vaccines, which is the Oxford vaccine, they actually have very good data from chimpanzee studies, which suggests that it may protect even against big inocula. So I'm very hopeful about these vaccines as well. And even if they don't work as well as predicted, what we need is something that helps another segment of the population to become less susceptible. Even if it doesn't give you complete protection, if you make a group of people less susceptible, that reproduction number, or the R number that Dr. Raymond showed, will come down. And that going down is the key thing for preventing community transmission.
Thank you. Dr. Raymond, I know we may quibble over who you root for, but I know you're a big college football fan. And that's clearly a pressing issue in the news today. Can you talk a little bit about your thoughts on college football under the current COVID conditions?
Yeah, thanks, Tim. As a fan, I really want to see college football this year. On the other hand, there are a lot of challenges. So if you think about sports, the NBA has bubbles that seem to be working very well. In other words, they have all the players, a small number of them, in a single facility where they're playing their games. So they're protected from the outside world. And there have been a few breaches where people have gotten infected, but generally they do okay. Compare that to Major League Baseball, which has a bigger challenge because they have much larger rosters and bigger coaching staffs, and they interact more frequently. There have been outbreaks that are pretty significant that may imperil the entire season. If you want to multiply that by 5 or 10-fold, when you think about college football, you have hundreds of people that you're trying to bubble. And they're going to be in violent, close proximity with each other at least a couple times a week. So that poses really huge challenges. On the other hand, I did hear Nick Saban say the other day that he didn't think it was likely that football players were going to contract COVID-19 on the football field. He thought that they would get it like many young people, just interacting in the real world. So we're in, really new territory now, and I don't know what the right answer is.
Yeah, interesting. And challenging decisions again all the way around to try to balance this. I'll ask all of you the questions. What are we doing well as a community or a country in treating COVID? what needs the most improvement, and what's the biggest opportunity to move the numbers downward?
Well, let me be the first one to answer this.
Sure.
I think that as a society, we should be more compliant in the United States with social distancing and masking. We will be much more successful in our country if we were compliant with this. And just to give you an example of why I am saying this, if you look at what happened in South Florida, specifically in Miami, a couple of months ago, people were behaving like there was not a pandemic going on, especially in South Beach, in some neighborhoods in Miami. 2 weeks after that, the spike of cases was incredibly high, and mortality too, right afterwards. Following that, the state put a mandate, actually not the state, the city put a mandate in which they closed all the bars, all the restaurants, all the beaches, and there was a mandate of wearing masks. What happened? The cases went down. That's what we need as a society. We need to be compliant with those two very basic things, masking and social distancing.
And so, Dr. Price, is there a balance here between just the example you gave of, kind of wide open or shut everything down? So in your example, if people appropriately social distance and mask where they should, can we operate in between?
Actually, I will give you a very local example of that. And it's what's happening in some of the buildings at MCW. So we are very compliant with masking and social distancing here within the building. And as far as I know, and I am in meetings with occupational health in a regular basis, we have not had transmission within the building. But we are fully compliant with those two mandates. So it's not an if or buts, we do it. And that's what other businesses need to do if they don't want transmission to happen.
And do we add hand washing to that list of yours?
Absolutely, yes. Okay. Yes.
So, Dr. Hari, thank you very much. Dr. Price, thank you very much. We appreciate your timely insights on the program today. Dr. Raymond, we've got a minute or so. Any closing thoughts from you about looking forward here for Wisconsin?
Well, let me just say there's a couple things that I'm optimistic about. I really do think that we're going to have some vaccines available in the short term. Say maybe 25% likelihood by the end of November, 50% by the end of December, and maybe 75% by the end of January. So I'm very bullish on that, and I think it's going to help us a lot. But I just want to go back to what Dr. Price said. Let's remember the 3 W's. That's the most effective thing we can do to keep our economy open and protect each other. Wash your hands, watch your distance, and wear a cloth face covering.
Thank you. You wouldn't think this far into the pandemic we'd still need those words of advice, but I think we do. And again, when enacted, they build consumer confidence and they help employees return to work, and that's where we're all trying to get to. So thank you again, Dr. Raymond, Dr. Price, Dr. Hari. Appreciate the time and insights. And we'll see you not next week, Tuesday, but the week after as we go every other Tuesday. And then again this afternoon at 3:20 on WTMJ 620, you can get Dr. Raymond and I. So thank you very much for joining us. Have a good rest of your day.
Thanks, Tim.
Much.
Bye.